most of you who must be aware of Destandau technique, the technique which I think brought in India around 2002. Dr. Rohidas, then myself, and then Dr. P.C. Day, we have seriously pursued this technique, and I think we have trained many our colleagues over years. And now, as the techniques have evolved, there are endoscopic, there are advances in field of spine endoscopy. So, sole purpose was to how to further innovations, advances which are taking place, how the Destandau technique which we have learned complements those newer techniques, so that if we have to graduate to those techniques, especially those of my colleagues who are Destandau users or arthrospine users or tube users, how you can graduate to a fusion surgeries when you are planning a kind of a endoscopic fusion. So my disclosures. So innovative techniques. Endospine system was innovated by Destandau in 1993, and then came the same, during that time only, Foley also was working on the system, and he designed a matrix system. And these two techniques, earlier it was a endoscope when Foley and I think Smith had designed, then probably there were some glitches, and then they combined it with the microscope. And the Destandau endospine system has stood test of the time, especially for discs, decompressions in cervical, lumbar and thoracic regions. And this has been, I will call it as a gold standard. This was the benchmark from where other endoscopic techniques, especially the interlaminar techniques, have evolved. And today we have enough scientific data to prove that these techniques are, they have stood test of time, and they are patient friendly, and outcomes are surely better than open microscopic procedures. So many references now in the literature available. When we started our journey of endoscopic spine surgery, we really had not much of the literature to support, and we had a lot of hostile environment when we were presenting our talks in various forums during that time. I am talking about year 2002 through 3 and 4. So any technique, minimal invasive technique or endoscopic technique, it should be minimal invasive, direct. It should show you the surgical target, direct visualization. It should preserve the surrounding tissues, and it should be a pinpoint precise targeted surgery, and it must preserve the motion and stability. This is what I think we have been talking. The natural function of the spine is to move. If we stop that movement by some artificial kind of putting in a graft or a cage there has to be logic and reason. There has to be a strong indication to do that. Otherwise, spine is meant to be in motion, or it's a mobile segment. So Destandau endospine system, I need not go into the details. We all know the parts of the Destandau system, and indications, virtually any kind of disc herniation you can address with this technique, whether it is in the canal or it is extraforaminal, you can address beautifully with this system. And just a demo case, one-sided herniation, patient positioning. Here we target a interlaminar window. We do a kind of a laminotomy, and then we expose the thecal sac and lateral part of the nerve root and do the discectomy in a standard manner. So I think around year 2014-15 it was occurring that endoscopic system, this was a good system for discs and decompressions, but when we were planning about fusions, there was surely a handicap with us, that how do we address the a patient where the fusion is indicated. So now there comes in the innovation, or you can say reinventing the pre-existing philosophy. So as we can say, innovation is successfully implementing a new idea to improve patient outcomes by providing new and better treatment options. And this is what Apple stated when he designed first iPhone in I think 2004. He said, we go to reinvent, otherwise we can't stand the competition in the market. And why reinvent? These were some reasons which were occurring to me, that how we can address these issues. And as in dry endoscopy, you can see as you are working, there is a swelling of the scope, and this is beautifully addressed by a starting a saline. When you are close to a surgical target, you can switch over to a saline mode, and your that problem is taken care of. So again, I was working on sort of innovation. Arthrospine first generation I worked in 2015. It is now Indian patent. And then 2019 I went visited Dr. Son, myself, Dr. PCD and Dr. Rohidas. And there I could, again my mind was working that how we can use endospine, Destandau endospine or arthrospine to switch over to a UV technique. So this is how I implemented that idea. And today we are routinely doing Destandau or arthrospine assisted UV fusions. So again the indications remain the same. So I named it as a arthrospine duo system, where you can use dry technique also, which we have learned, mastered, and then you add the switch over to saline whenever it is required or needed. So in saline mode is recommended when we are working close to a surgical target, and continuous saline inflow and outflow ensures constant hydrostatic pressure at surgical target, and there is a clear enhanced field of view. So even when you are doing a UV, especially in the early years of learning, there are certain issues. There is a difficulty in triangulation, getting lost in soft tissues. There is a red out phenomena, excessive radiation, and these are the issues which we could address by combining a dry technique and a saline technique. So I'll share here with you how we switch over from a tube to a UV technique. You can see here, this is a working port. Here, this is with the Destandau tube. You can see here. Here I am showing it with the arthrospine tube. You create an additional stab incision. So there is a sounding. I call it as a tube sounding or a Dr. Kaushal sounding technique, where this is a Wissinger rod which you orthopedic surgeons use in shoulder arthroscopy, or switching stick we call it. You are trying to hit the tube and you get that typical metal sound, and you know that you are not haywire or you are not at a wrong place. Then this scope is withdrawn and this working insert is withdrawn, and this is a typical like arthroscope, but it is a uniportal sheath here. This is a little modification, and then you slide this arthroscopic sheath over this Wissinger rod. This is how it goes. Right? You always feel the bony feel and the metal feel, and then you put in the 30 or 0 degree scope as you have in your printer. You can use that, and the fluid is started, and this tube is withdrawn. Now how the fluid is coming up, you can see here, and the surgeon, this is not working, so surgeon starts working then in a standard usual way. Same can be done with the Destandau technique, as you can see there I have shown. So just few demo cases I'll show, but I think this is a simple case where I will fast forward it. Dry, and after dry you switch over to saline mode. See here, you can switch over to saline mode and you can work in standard way. Similarly, paraspinal approach you can use. You can address all type of herniation. This is up migrated disc, this is a down migrated disc. I'll not show the video because time doesn't allow. Redo disc you can do, and lumbar decompression. Here you can see when you're close to the surgical target, you can switch over to saline mode. Then there is a cervical laminoforaminotomy. This is another very good gratifying procedure for patients, and here you can retrieve the disc fragment, and these patients are very, very happy immediately, same evening, few hours after the procedure. And then cervical myelodecompression. This is I think 3 or 4 level decompression. This is again under the spinous process. You leave the spinous process on top, and you can say cervical laminoplasty. Spinous process remains on the top, and you work and you take away the opposite side lamina also here. Endofusion, I will not go into this detail. And then I think since 2002, 5,000 plus procedures we have done, and with the good outcome. We had our share of complications. And just a word about learning curve. Whenever you want to learn or master any procedure, first step should be you visit that surgeon who is routinely doing these procedures, spend few weeks with him, then probably after that you're convinced that yeah, this is a procedure which you want to learn, then you should try hands-on workshop and finally try and do this procedure in your own theatre setup. So journey from Destandau to arthrospine and then arthrospine due. So it's always there is a evolution going on. You can't put a full stop ki now beyond this I will not move. I think the life should be evolving, and the same way our techniques also keep on evolving. And so just to summarize, the techniques are effective for discectomies and decompression in the cervical, thoracic and lumbar regions. Techniques have proven efficiency. Studies show that better outcomes compared to traditional surgeries. And fusion can be now thought of. Now from Destandau to arthrospine, surgeon who wants to go ahead with a fusion, he can plan that also by converting to a UV mode. And even when you are using a fluid judiciously, the fluid related complications are minimized. Otherwise, surgeons when they are doing a fusion in UV, they end up using close to 60 to 80 liters of fluid. So there are issues with the fluid also. So here there is again, surgeon can be more judicious with their fluid use. Thank you very much.